going to turn my video off here so we can just focus on my PowerPoint. So I'm Brenna Bray. I have a PhD in biomedical science and neuroscience, focusing on the impacts of stress hormones on the brain and how they impact reward functioning. My postdoctorate work was funded by the NIH, the National Institute of Health, and specifically the National Centers for Complementary and Integrative Health, focusing on kind of the intersection between nutrition, mental health, eating disorders, and public health, and really with a focus on eating disorders. And so that's what I'm going to talk about today. And specifically binge eating disorder. I'm the director and founder of the Nourished Research Foundation. I am an adjunct, I'm an associate professor at the National University of Natural Medicine, both in their undergrad, graduate, and in their postdoctoral program. I'm faculty at the NCCIH, and I'm an adjunct associate professor at Naropa University in their clinical mental health counseling master's program and in the undergrad. And I'm going to begin. I want to give a little disclaimer. This presentation is going to contain content related to oppression, invalidation, marginalization, discrimination, bullying, abuse, and trauma, both generally and specific to populations of racial, ethnic, sex, gender, and socioeconomic status minorities, because binge eating disorder contains all of that content in it. If you find this activating, I encourage you to take care of yourselves. Feel free to, step away and move through the space as you like. And I'm going to ask that everyone close your eyes for a moment. I like to start with a little exercise. So I want you to imagine, for those of you who are clinical care providers, that you have a patient who comes to you. And for those of you who are not, just imagine that you have a friend or family member who comes to you and expresses negative emotions around their food or their eating. Maybe they have guilt, shame, loss of control. I want you to think about how you might respond. Are there any particular follow-up questions you might ask them? And now I want you to just notice what, if any, imagery comes up for you about that patient or friend or family member. Do you notice anything about their body shape or size, their sex or gender, their race or ethnicity, their socioeconomic status, their age, or any other demographic factors? And I can go ahead and open your eyes. Thank you so much for indulging me there. I'm going to kind of give the qualifications right out the bat. So the data that I'm going to be presenting is largely published in my 2022 publication from my postdoctorate work. That's called Binge Eating Disorder is a Social Justice Issue. There's a little QR code here if you'd like to scan it and follow along. I am well established in the field. I've published on environmental factors in binge eating disorder, mental health factors in binge eating disorder, clinical factors in binge eating disorder, as well as complementary and integrative health intervention use in binge eating disorder. And we're getting ready to publish 3 manuscripts on treatment barriers. So what is binge eating disorder? Binge eating disorder is an autonomous DSM-5 diagnosis, meaning that it is distinct from other eating and feeding disorders. It is very different, very distinct from anorexia nervosa and bulimia nervosa, as well as OSFED, otherwise specified feeding and eating disorders. It's characterized by 2-hour binge eating episodes, approximately 2 hours, that occur at least once a week for at least 3 months. In those episodes, individuals rapidly consume large amounts of food, larger than others would in the same context, which can be very difficult when you're trying to diagnose adolescents. This often occurs in isolation due to embarrassment. It's associated with feelings of disgust, guilt, and shame. Those are core diagnostic criteria, and a loss of control around one's food and eating. And I said often here, that actually is a core diagnostic criteria. So always in the case of binge eating disorder, that is present. It has high comorbidity rates with other mental health issues, 89% comorbidity rates with other mental health issues that include substance-related and addictive disorders. This includes alcohol use disorder, substance use disorder, as well as sex, love, gambling disorders, high rates of comorbidity with depression and anxiety, trauma, adversity, and PTSD. The rates that we're starting to get on adverse childhood experiences are around 60%, and adverse lifetime experiences around 80%. High co-occurrence with neurodivergence, so attention deficit disorder, attention deficit hyperactive disorder, autism. And the data that we have emerging shows that oftentimes these comorbidities go undiagnosed. And it's thought that in many cases, binge eating is actually used to cope with or mask these untreated symptoms. It also has high comorbidity rates with other physical health issues, so 80 to 90% comorbidity with lifetime obesity, as well as overweight, diabetes, metabolic syndrome, and cardiometabolic disorder. Though we do have some data showing that in individuals with binge eating disorder, overweight and obesity do not necessarily increase risk for cardiometabolic disease and disorders. So we need to be very careful with how we're thinking of weight in individuals who have binge eating disorder, and I'll circle back to that a little bit later. It also significantly impairs daily life. It accounts for almost 1 year of disability adjusted life per person. That's 9.8 disability adjusted life years in every 100 individuals, 0.8 million disability adjusted life years total. And that data is from the 2019 Global Disease Burden Database. Now, we usually think of anorexia nervosa as being the most common, the most prevalent eating disorder. Most providers, that's what they're thinking of when they're thinking of an eating disorder. But binge eating disorder is actually by far more prevalent and by far more serious in some cases. It has very high lifetime prevalence rates that are estimated at 23 to 31%. That is the same as the lifetime prevalence rates for generalized anxiety disorder, major depression disorders, substance-related and addictive disorders. So depression, anxiety, addiction, it has the same prevalence, and yet it gets about 1/10 the amount of federal funding and research and goes highly underdiagnosed and underscreened. The 2019 Global Disease Burden Database estimates 23.4% of individuals will experience binge eating disorder at some point in their lifetime. That's 17.3 million individuals. And not only does it have high prevalence, but it is growing rapidly. So the compound annual growth rate for the binge eating disorder market is estimated at 6% between 2025 to 2034. We're going to see a 6% growth rate in binge eating disorder. And this is just when we're thinking about the market value. And I'm going to circle back to that in a minute. But so we're looking at market value data here. So people who are purchasing pharmacotherapies, pharmaceuticals, things like this, counseling for binge eating disorder. The market is valued at 0.81 billion US dollars in 2024. It is thought to be driven by increasing awareness, which is fantastic, advancements in treatment options, and the rising prevalence of the disorder across the 8 major markets. And I'll just add here one thing that some of the experts in my research have shared is Vyvanse, which is one of the approved pharmacotherapies for binge eating disorder. It's a stimulant, it's an amphetamine. They were unique in that they used a direct-to-consumer marketing plan. So rather than marketing to providers, they marketed direct to the consumer. A big benefit of this was that it increased awareness of binge eating disorder. We saw increases in prevalence rates, increases in diagnoses, which is actually fantastic. It doesn't mean that the disorder is increasing. It just means that it's getting detected more, which is phenomenal. And this isn't expected to increase by at least 6%. In 2034, the market value will be 1.45 billion US dollars. Standard of care treatments for binge eating disorder usually are behavioral. Cognitive behavioral therapy is the kind of standard of care. Behavioral weight loss, interpersonal therapy, and pharmacotherapy, so medications, also have guideline support. Pharmacotherapies tend to include selective serotonin reuptake inhibitors, so escitalopram, sertraline, anticonvulsants like topiramate, anti-obesity medications like orlistat, though that is no longer FDA approved, Vyvanse or lisdexamfetamine, which is on label for ADHD, is also approved off label for binge eating disorder. And then, of course, GLP-1 inhibitors, we're seeing a huge uptake in use, though they are not guideline approved. These would be things like Ozempic, Wegovy, etc. Other evidence-based practices and treatments that have increasing use include family-based therapies, other psychodynamic therapies, humanistic therapy, dialectic behavioral therapy, guided self-help approaches, so CBT, DBT, guided self-help, and mindfulness-based interventions like mindfulness-based stress reduction. Despite all of these treatment options, these interventions collectively have very low treatment success rates. They cap at 45%. They have high rates of recurrence. 50 to 65% of folks who do access treatment have relapse or recurrence of their disorder. It has high rates of treatment dissatisfaction and high rates of early discontinuation of care. We also have really big gaps in self-recognition, clinical detection, and care. So data shows us that most individuals with binge eating disorder, 95% don't know themselves that they have an eating disorder. 95% never receive a formal diagnosis. 56 to 87% never receive standard treatment, and 85% lack access to health care. This is a really big issue in the field. And I'm going to circle back on that, but I want to touch on another issue that we have in the field, which we call in the field the swag stereotype. It's an outdated misconception that ascribes all eating disorders to skinny, white, affluent young women or girls, swag, usually with restrictive type eating disorders. So I want you to think back to that contemplative exercise that we did in the beginning. Does that align with the demographics that you were envisioning when you were thinking of someone who might come to you and talk about difficulty with their food or eating? The reason that this is important is because this demographic tends to historically saturate treatment-seeking populations for eating disorders. This demographic also saturates treatment-seeking populations for mental health and Western allopathic healthcare across the board. And historically, research tends to pull from treatment centers and treatment-seeking populations. So we have this scenario where the research that we have that informs our understanding of binge eating disorder comes from treatment-seeking populations, which are historically saturated by this white, affluent, thin, restrictive type eating disorder demographic. However, that demographic represents less than 5% of all individuals with binge eating disorder. This is a huge issue in the field that experts are very, very aware of. We have a cultural and a global situation where our understanding of eating disorders is wildly inaccurate. And that leads to underscreening, underdiagnosis, misdiagnosis, mistreatment. It leads to stigmatization among healthcare providers that drive 85% of individuals to avoid healthcare systems altogether because they are not getting the help that they need. And this is all published in mine and others' works. So I'm going to read a quote from one of the experts in my research. So much of the eating disorder perspectives in history that we attend to are very female-focused and come out of the female gender orientation. I think anorexia nervosa kind of set the stage for a current understanding of eating disorder pathology and treatment, and anorexia is so dominantly female. We know that unfortunately eating disorders have been hampered by these old stereotypes about who's affected, and that leaves millions of people undetected with an eating disorder. So this swag stereotype, it needs awareness, it needs dismantling. We need updated information on binge eating disorder. We need updated information on the demographic, prevalence, risk factors, pathology, and we need that data, that research to include the 55 to 95% of individuals who go undetected, unscreened, undiagnosed, and untreated, who maybe don't know they have binge eating disorder, who don't get a formal diagnosis, and who don't end up in treatment. So again, this is all largely from my 2022 publication on environmental factors associated with binge eating disorder. And I want to just give a quick validation for this research. So this comes from a mixed methods cross-sectional study that I conducted in my postdoctorate work. We developed criteria to identify experts in binge eating disorder. This included researchers, clinicians, healthcare administrators, policymakers. That criteria was based on federal funding, PubMed index publications, professional leadership, popular press, as well as Google ability. We wanted to also include, if you're Joe Schmo on the street and you have binge eating and you are looking for help, who are you going to find? We wanted to capture that as well. So we had different eligibility criteria for researchers, clinicians, and then a combined category that included a little bit of both to help capture nutritionists, dietitians, and kind of more popular press-oriented folks. That criteria identified 38 experts globally, and 14 of them consented to participate in 2-hour semi-structured, anonymously recorded Zoom interviews with me. So that's almost 50% of the global experts we were able to capture here. So this data does really have strong validity. This included 7 researchers, 6 clinicians or healthcare administrators, 2 who met the combined category, and 1 who separately met the research and clinician category. I interviewed these individuals in 2-hour semi-structured, anonymously recorded interviews. Then we used a qualitative research data analysis technique called reflexive thematic analysis. We took the interview transcripts, the interviews, we transcribed them, we went through the transcripts, we identified themes, both myself and one other investigator who was my mentor on this project, Dr. Heather Zwicky. And then we've published the themes in separate manuscripts. So the first theme that we identified was environmental factors. That came out in that publication we put out in 2022. The second theme was mental health aspects. That publication also came out in 2022. Third theme was clinical factors. That came out in 2023. Last year, we published on complementary and integrative health intervention use in binge eating disorder. This is like a 50-page manuscript. I was so grateful that they let us include all of this content. Funding is difficult right now in the US, as I'm sure many are aware. We have 3 manuscripts that we're hoping to get out on treatment access barriers and several more lined up. But I'm going to focus on environmental factors. We've got about 7 minutes left I'm showing. So the environmental factors that experts most strongly identified with binge eating disorder are maybe not what you think. They don't have anything to do with perfectionism. They don't have anything to do with trying to restrict your food to control your body weight. Here's what they were: gaps in clinical research and care. We as researchers and providers are not doing our jobs good enough here. Invalidating environments and experiences, systematic issues and systematic oppression, marginalization, lack of resource access, economic precarity, stigmatization, discrimination, trauma and adversity, food insecurity, interpersonal relating, social media and social messaging, nutrition scarcity, predatory food industry practices and environments. So I'm just going to go into a few of these. In the theme of systematic issues and systems of oppression, there were 12 systems of oppression that were identified as relevant to binge eating disorder pathology by experts. These included systemic discrimination. This could be discrimination based on body weight, shape, or size, as well as structural racism, structural sexism, social media, sociocultural ideals, social media, which largely echoes these discrimination factors and carries them, insurance and healthcare systems, predatory food industry practices and environments, and forms of abuse, sexual abuse, emotional abuse, physical abuse, geographic systems of oppression, clinical factors in the field of eating disorders. So stigmatization, stereotypes among healthcare providers that not only leads to underscreening and lack of detection, but also leads to healthcare avoidance, and I'll touch more on that later. This anorexocentric thinking that applies what we think we know about anorexia to bulimia and to binge eating disorder, which is wildly inaccurate and actually very, very harmful for patients who have binge eating disorder. Federal funding for binge eating disorder research, economic exploitation, school systems, legal systems, police harassment. This gets into some pretty heavy stuff pretty quickly. So a quote from one of the experts, how we think about eating disorders is that anorexia was kind of the granddaddy, the thing we knew first, and then bulimia kind of grew out of that next. People used to refer to it as failed anorexia, and I would say that in part, binge eating disorder was thought of initially as being like bulimia, but without the purging. So the same mechanisms. And I would say traditionally, when I'm talking to colleagues in the eating disorder field, the dominant mechanisms that have a tendency to be most thought of are things like restraint and shape and body weight overvaluation. But there's starting to be a bigger push to have a more encompassing view on mechanisms like reward, inhibitory control, emotion, distraction. I would add trauma, adversity, things like that. I think in part because the restraint stuff wasn't necessarily panning out with binge eating disorder quite well. And this quote was made back in 2022. This has only amplified. All of the data that we continue to collect, one of the huge benefits of COVID-19 was that it put a firewall between research and treatment-seeking populations. So as researchers, we had to get creative about how we were going to continue conducting research through the pandemic when we couldn't necessarily access treatment centers. So we started seeing research becoming more inclusive, capturing individuals who maybe didn't have a formal diagnosis, who weren't able to access treatment. And that has hugely informed our understanding of binge eating disorder. I look at it now almost as a stress and trauma related disorder rather than a feeding and eating disorder. The feeding and eating behavioral piece just happens to be a manifestation that is easy to observe and operationally define. So why am I showing a dolphin here? I want to make the point that was really hammered home by one of the experts. I think in mental health, a lot of what we do, we see commonalities behaviorally, superficially, and then we make deductive applications. So we see binge eating disorder and we go, oh, it's eating. It must just be like anorexia and bulimia. But dolphins and sharks look and behave quite similarly, but one's a mammal and the other's not. If you look superficially, a lot of things can look the same. But I think we need to try and understand these more completely to see if such apparent communality is supported. We need to review the data. So I've got about 5 minutes left. Marginalization and underrepresented populations. This was a huge theme. This includes folks with low socioeconomic status, economic precarity, insecurity, which was also, all of these were also themes independently, food and nutrition scarcity, sex and gender, specifically the male sex and gender orientation, racial and ethnic minorities, including members of the BIPOC community, sex and gender, I would add to that members of the LGBTQ2 plus community, age, religion. So I want you to think again about the person who you imagine coming to you talking about their eating. And now I want to share with you what the demographic data that we have tells us individuals with binge eating disorder really look like. Members of the Black, Indigenous, and members of Black, Indigenous, and people of color populations have higher eating disorder prevalence rates than their white peers, twofold, 2 times higher. And yet they are 50% less likely to be screened, diagnosed, or receive care, and they are included in less than 10% of research. Members of the LGBTQ2 plus population have 3 times greater risk and prevalence rates of developing binge eating disorder than their heterosexual cisgendered counterparts. Gender minorities have 70% rates of eating disorders, 30% binge eating disorder prevalence rates. So again, that swag stereotype, that is not an accurate representation of everyone who experiences binge eating disorder. And if you are a provider, please screen indiscriminately. Screen your BIPOC patients, screen your LGBTQ2 plus patients, and screen your Medicare and Medicaid patients. So quote, if you are a Black woman, if you are somebody who lives in a larger body, if you are an older male, people aren't going to think that your eating habits constitute an eating disorder because you don't match that swag stereotype. You aren't a young, thin, cisgendered white woman. Oops. I think it also makes sense to talk about the specific ways in which underrepresented groups might be struggling that are unique to them and their experiences, rather than just saying everyone can be affected. So knowing, for example, that if you are a sexual or gender minority, you are at much greater risk of developing any kind of eating disorder behaviors. Knowing that if you are a member of a BIPOC community, you are not only at greater risk, 2 times greater risk, but you are very unlikely to get detected with an eating disorder. And that means that you could struggle for a long time. And what do we do then to reach these communities in a way that's meaningful? And very quickly, I just want to touch on economic insecurity, food insecurity, and nutrition scarcity. So food insecurity increases the risk of binge eating disorder almost twofold. Using government assistance before the age of 18 increases the risk of binge eating disorder threefold. We have studies now coming out of food pantries, 2 food pantries in San Antonio, Texas, as well as internationally. They all report broadly the same data. 52% of folks who use food pantries meet diagnostic criteria for an eating disorder, usually binge eating disorder. That's over half. Usually they report going 8 hours or more without eating or trying to restrict their food. When they report that, it significantly correlates with increased weight and BMI and increased eating disorder pathology correlation coefficient of 0.25, p-value 0.0001. What these folks will say, well, yeah, I have binge eating disorder. I binge eat the first 2 weeks of the month because that's when we have food in the house. And then there's no food in the house the last 2 weeks of the month. The reasons these individuals report restricting their food, this is so important. 1, insufficiency. The food allotment is not enough. They're stretching food to make it last longer. 2, prioritizing other family members. So this is a mother who's eating less so that her child can have more. And prioritizing medical expenses, so diapers or tampons over food. This is not an individual who needs a treatment that helps them love their body or helps them let go of perfectionism. This is a treatment this is the story of an individual who has a very real food insecurity. And they are taking a cognitive tactic to try to manage that, and it happens to not work. So giving these individuals a standard eating disorder focused cognitive behavioral therapy that is developed in treatment-seeking women with anorexia and telling them to not be afraid of food is not the solution. In fact, it is harmful. I believe it is why our treatment success rates are so low. We need a better understanding of this issue. Lastly, I just want to touch on stigmatization and discrimination, which really go hand in hand with trauma adversity. I mentioned, since I'm not going to get to this, 60 to 80% of individuals with binge eating disorder have adverse childhood experiences or adverse lifetime experiences. One of those is the stigmatization that they experience. That stigmatization includes stigma around body weight, shape, or size, around having an eating disorder, and around having a mental health diagnosis. Now, this is a quote from an expert in my study. I have a patient with binge eating disorder whose doctor told her, "You're fat every day, so you should exercise every day." That's from a healthcare provider. But that's really what we're telling people as a culture or society. The practitioner just put it into words. The sources of this stigma are not just sociocultural, and we're about to publish this. This type of stigma that contributes to healthcare avoidance, it does occur socioculturally. It does get internalized and occur in the patient, and it occurs among healthcare providers and in healthcare systems. We are not doing our jobs. The impacts cannot be understressed. They contribute to shame, trauma, adversity, adverse childhood and lifetime experiences, PTSD, poor self-esteem, interpersonal relating, isolation, avoidance, which worsens mental health, and healthcare avoidance. If the eating disorder has been associated with weight gain, then we know for a fact that the individual has been intruded upon by families, doctors, institutions, and there's trauma associated with that. There's trauma associated with being told day in and day out that what you are is not acceptable or lovable or okay. Many people who are living in larger bodies have been teased or bullied around weight, so there's a lot of trauma associated with binge eating disorder. Now, I've got half a minute left, so I'm just going to really rapidly We're doing some very cool network mapping work at the Nourished Research Foundation to explore how these factors relate to one another. Largely, they can all be viewed as forms of trauma and adversity. So what do we do about that? Number one, tabula rasa, we need to be taking a blank slate. Forget what you think you know about eating disorders. We need systematic screening, detection, diagnosis, especially in marginalized populations. We need a better understanding of weight bias and stigma and discrimination, especially in healthcare systems. We need to be taking and raising patient narratives. Listen to your patients. And I think that's my time, so I will pause there. We have a lot more research and a lot of work that we're doing at the Nourished Research Foundation. Let me just go to my last slide here. And I'm happy to talk to anyone on any of this individually. Thank you so much.